Okay. So welcome all of you. This is way more than I'm used to seeing. So I understand you guys have your two teachers, Showalter and Hughes, and they cover different content. Is that true?
It is.
Okay, so Showalter was telling me that she's going to come back at 4 and go over her stuff, her content. So Hughes asked me to go over her things right now, specifically like heart failure, right-sided, left-sided, CHF type of stuff, MIs, things of that nature. So we'll go over that kind of stuff first, and then if you guys have like other questions, we can go over. I'm not going to say no if you have a specific question, right? Does that make sense? I did two other ASAPs where I covered all the stuff from hemodynamics through everything. So I'm going to try and focus on the things that I haven't talked about yet. So starting with core pulmonale and kind of going over some heart failure that ties into it. And then MI things, and then I'll just kind of ask questions after that, if that's cool, since I already kind of did material on the other ones with previous recordings. I don't know if anyone's seen those or not. Okay, so let's start, I guess, with some core pulmonale. Come on. Let's share out of the way. This isn't working. All right, core pulmonale. Who wants to tell me what this is? Just shout it out. Not signs and symptoms, but like what it is. Right, so it's right-sided heart failure because of what? What's it caused by? And that would be left-sided. Nope.
From left-sided.
I'll give you a hint. It has it in the word. All right, so any pulmonary disease or pulmonary cause. So I'm going to put due to lung issues, right? So this is easy to remember because core, that's the root for heart, like cardiac, or in Spanish, corazón is heart, and then pulmonale has the root pulm, like pulmonary. So it's heart issues directly resulting from lung issues, right? So let's say, let me just see if I can draw this picture. Going to be a beautiful drawing. You're all going to love it so much. Okay, so I know this isn't the shape of the heart, but we're just going to do this for it being easy to look at. So this is the right side of the heart. This is the left side of the heart. And you got your pulmonary arteries that go to the lungs, right? I'll put lung right there, right? And then the lungs, from the lungs, it comes back to the heart via the what? The pulmonary veins, right? Pulmonary veins. So let's say someone's got some lung issues, right? What are some common lung diseases? COPD, pneumonia. Yeah. You guys know about cystic fibrosis? You talk about that at all? These are some common ones that can increase the blood pressure within the lungs themselves, especially COPD. This is the most common. Everyone and their mom has COPD, it seems like. It increases the blood pressure in the lungs itself. And so if there's a lot of pressure being built up in the lungs, it's going to make it much harder for the right ventricle to pump blood up into it, right? Because it's all of this, it's going to be a lot more pressure. So it's this, how we would measure that, this is what hemodynamic measuring measures the pressure here. Yeah, so CVP. If the pressure is too hard, it's like trying to pump something really, really small, right? Really, really tight. So it's having a really hard time. The heart's having a really hard time pumping the blood to the lungs where where the blood can get oxygenated, right? So that will lead to the right heart failure because all the fluid that's supposed to be pumping through to the lungs to get oxygenated is still just kind of building up right here. Does that make sense? And just like in left-sided heart failure, which is caused by fluid overload, like you said, it causes the heart to stretch out. So it starts, making it stretch out like a water balloon. And when the heart muscle stretches, it's like one of those scrunchies that you like stretch out too much and then it loses its elastic and it's no longer like super good for like tying your hair up. It's like, you know what I'm talking about? Like when the scrunchies lose their stretchy and they don't really work so well. So the heart had lost its ability to like contract and squeeze really well. So now the pump is weakened, right? So it's not able to even pump to overcome the resistance to get to the lungs. Does that make sense? You guys with me so far? Yeah. So now the heart is weakened, not able to pump blood through. What is that going to do to your cardiac output? Decrease it, right? What's this going to do to your activity tolerance? It's going to decrease it. Why? Right. Well, one, because your cardiac output is decreased, so you're not getting as good blood flow, but also all the blood that's supposed to be getting oxygenated is like not getting to the lungs that great. So you're not having as much oxygenated blood. That makes sense. So you need oxygen to be able to exercise and all those different things. What other signs and symptoms would you expect to see with someone with core pulmonale? Shortness of breath. I mean, that makes sense, right? Like you're trying to breathe more to compensate.
Enlarged spleen and liver.
What was that?
Enlarged spleen and liver.
Yeah, hepatomegaly. And we'll talk about that in a second. We'll put hepatomegaly here. Hepatomegaly is just the enlarging of the liver. And that happens because the same reason for JVD, the jugular vein distension. So all the blood that's supposed to be like pumping through in a nice like circuit is getting backed up and backlogged. So if it's not getting through here, it's backing up to here, it's going to back up into here and into the rest of the body. The vena cava is what brings all the blood to the heart. So the jugular vein is getting backed up because it's not getting flowed through. So you're going to have jugular vein distension. Same thing with the big artery in the liver also. So it's just getting backlogged with fluid. So lots of things are just getting backlogged. What else we might see as an example of fluid? Edema, right? So all these three things have to do with the fluid backup. Does that make sense? Those three things kind of make sense why you would see those. And then obviously chest pain. That's kind of a sign and symptom with everything related to the heart. So what else? What can we do to treat this? Can you do much? You can. Usually that's more for a left-sided because the cause is really from a fluid overload. From the research that I've seen about it, like it's kind of, there's mixed opinions about whether diuretics are good for this. Some say it helps, some say it kind of weakens, it dilates the vessels and it makes it even harder it reduces the pressure to pump past getting into the lung even worse, if that makes sense. So I kind of guess it depends on the cause.
Are going to treat in this case the cause or let's say the heart or the lungs?
Well, yeah, it depends on what's causing it. So most of the treatments you're going to do is to be treating the symptoms. So they're having shortness of breath. They're also going to be having hypoxia because not adequate blood flow to the lungs. So oxygen is always going to be something you're going to give people whenever there's decreased cardiac output or lung issues. Always going to give them oxygen. Generally, core pulmonale has a pretty poor prognosis, unfortunately. So most of the stuff you're giving is to treat signs and symptoms. So one of the things you can give is bronchodilators. That directly impacts the lungs. Because remember, the lungs is the main issue. Like that's the underlying cause. It's not necessarily that something was wrong with the heart, but the heart just got affected. Does that make sense? So bronchodilators will help open up the vessels in the lungs and get that airflow. Giving a fluid restriction can also help. You see like little signs on the doors in patient rooms about fluid restrictions. What does the rest of your notes say? I don't have you guys' specific notes. I have my notes from back in 2015. Perfect. Yeah, dobutamine is a good one. What do you guys know about dobutamine?
But with that being said, since the pressure in the lungs in this case would be elevated, would you mix it in with some type of beta blocker, ACE or others to decrease the blood pressure as well?
What does your specific note say? Because I don't want to tell you wrong. Yeah, because the notes that I have
doesn't specify as far as
yeah, the notes that I had and what I looked up on the internet didn't really say much about that either. But dobutamine, what is the action of dobutamine? What does it do?
Increase the course of the
Right. And this might be dumb, but how I always remembered this one for some reason was I always like in my mind called it dopumpamine. And it's because it helps the heart to pump better, right? So it like increasing the force of contraction was kind of like a abstract like thing in my mind, but like thinking of it as like it helps the heart to pump better, making it stronger. That's how I remembered it, to remember what dopamine does. This is also really helpful for left-sided heart failure, which we'll talk about just in a second. They're actually very similar. They have similar signs and symptoms, similar, they have a few differences. The thing with the thing about the pulmonale and the right side of heart failure is that this can also, all of this can happen as a result of left-sided heart failure, right? Because we know things start in the left side, it backs up to here, then it can back up into the lungs, and it can back up to the right side. So a lot of right-sided heart failure can be caused by left-sided heart failure. Does that make sense? So right-sided heart failure can be caused from specifically lung issues or from left-sided heart issues. Does that make sense? Go ahead and erase that. Is it okay to erase it? When done. Let's talk just a real quick, because I don't know how much this was emphasized or not, but it was mentioned in the text from Dr. Hughes to me, and I noticed it was on some of the test study guide that you guys got about like different locations for heart attacks. So I'll just quickly go over that just in case. So there's anterior infarct, or MI, we'll put infarct. And this can also be called the LAD, or left anterior descending. I'm going to draw like a heart with the little valves, or looks like a strawberry. Sorry. It's fine. So the left anterior artery comes off of the aorta, and it kind of just goes down this side, you know, little branches off of it. So this one is the LAD, or the left anterior descending. There's several arteries that come off to perfuse the heart itself, right? Because the heart needs blood flow as well. And so if those get blocked, that's when you have your heart attack. So the left anterior descending, this one, let me just throw that at you. I'm so sorry. Thanks. This one is sometimes nicknamed the Widowmaker. Have you heard about that? So yeah. That's kind of a sad name for it to be called, but typically, not always, but typically men have more heart attacks than women do, and so they call it the Widowmaker because the men die and then it leaves the women as a widow if they have this problem. This one specifically, let's see. What kind of heart failure do you think this causes?
Left-sided.
Left-sided, right? And so the left-sided is the one that's worse because it can cause lung issues, and right-sided, right? So this starts backing up, goes to the lungs, which are here. I don't know how to draw a lung, that's fine, whatever. And then it can back up into this side. So what also can this cause besides left heart failure? Well, and besides the lungs and the right, what other heart issues? Dysrhythmias. So lethal dysrhythmias. And what kind of dysrhythmias do you think those would be? Well, not AFib, but VTAC and Vfib, right?
I think she told us AFib. Yeah.
Really? In my notes, it says not AFib. Weird. When from Monty Young.
She says like, because AFib's like, because she mentions SVT, pretty much is.
She specifically said it causes AFib?
It says it right here, it says dysrhythmia to new onset of AFib. And then she said that it was AFib to the left side.
Specifically for the LAD, because I know new onset of AFib can be a side effect of an MI, but not specifically to this one, because on my notes it says not AFib. But if that's what she said, go with that, because I don't want to lead you astray. Because
there was a quiz question where one of the options specifically mentioned like Those.
Because, no, I do have a note that says that a new onset of AFib is a side effect of an MI, but there's, what I'm drawing here is like different locations you can have an MI.
I
So-
have lethal dysrhythmias, VTAC or Vfib,
Yeah,
and PVCs,
yeah.
but that's under MI complications, but I don't have AFib on this one.
That's probably.
Okay, well, this is my understanding, you might be able to ask her, because I don't know what she's taught, but I know it is true that new onset of AFib can be a sign and symptom of a heart attack, but there's different locations in your heart that you can have a heart attack. Does that make sense? We're talking about the anterior one right now. There's also the circumflex, and then there's also the inferior, right? So what I was taught and what I have in my notes was that Vfib, VTAC and Vfib, because we're talking about the ventricle over here. So that might be a question you might want to send her an
On the
email.
other page, I have it wrote in AFib, left side AFib and VTAC.
Does it say that on there?
She had us writing in dysrhythmias, a new onset of AFib
Interesting.
with signs and symptoms of MI.
That's interesting. Well, yeah, that's again, we're talking about MIs.
Yes, but then here under MIs, MI complications, lethal dysrhythmias within the first hour.
Is it
VTAC or
saying
VFib.
which kind of MI?
Anterior.
It just says,
Well, if someone wants to make a note of that,
ask.
I can ask her in a
I'm
text.
emailing her right now.
Huh?
I'm emailing her right now.
Okay, perfect. I don't want to be the reason, like,
Exactly.
that girl told me an ASAP.
I wonder if she meant
No, just
Vfib
text her,
when
I
she
never-
said- I don't have to have her, that's fine.
I don't know. Yeah, again, I'll ask her if someone makes a note. I can send her a text later. So we'll just keep going. We'll put a pin in that one. At least for sure, we know these two, right? We know for sure that it'll cause these two types of dysrhythmias. That's not up for a question. And VTAC, Vfib. This is VTAC. Vfib looks more like random, right?
So it is the first set points there.
I'm sorry, I can't hear you.
Is it the first set's
Torsades.
first points or no?
This one, I was
No,
just
the
drawing.
second one.
This one is Vfib. Torsades looks like VTAC with like a wave. So,
Oh, okay.
so it
It's
would
the
look,
or the polymorphic,
it's hard to draw that.
correct?
So it's,
Yeah, so it's like, it like slowly undulates bigger and smaller, if that makes sense. Does that make sense? So it kind of like looks like a wave. Does that make sense? So this is the one that has to do with the magnesium and the torsades. This is the monomorphic and this is the polymorphic. Mono meaning one because it's only like one wave size, whereas this is polymorphic because it has multiple waveforms. Does that make sense? Okay,
So the second, the magnesium one is not part of this, or it is?
well, this is part of VTAC, yeah, it depends on like, are they also having a magnesium issue, right? So if they're having magnesium and electrolyte imbalances, you would probably see this too. But for sure, like these don't have anything to do with the electrolytes. These are just if they're having, if you're not perfusing the part of the heart that's responsible for pumping of the ventricles, then you're gonna have dysrhythmias because like it's pumping kind of weird. It's just like kind of trembling instead of like giving a good squeeze. So the fibrillations, right, are just kind of like the heart's going like this and just kind of like twitching instead of getting a good pump, if that makes sense. Good, yeah. Okay. Where are we at now? Okay, so that's the anterior. We'll draw the next one. Should I erase this or just draw it next to it? Alright, so we'll do, can you see down here if I write here? I still don't think you can see from back there. So we'll do the inferior. Let's see if this is still on the video. Yes, it is. Okay. So inferior, this is also called the RCA. And what does that stand for? Right coronary artery. And so that one looks more like, yeah, heart strawberry again. Looks more like this. You got your aorta there and it branches off kind of like that. Beautiful drawing, yes. So this perfuses the right atrium, the right ventricle. You can, drawing it kind of helps you see why, What else does it perfuse? Anybody?
She said that SA and the AV nodes. are part of
Perfect.
it.
Yep. Perfect. So can you imagine what kind of issues you would have if the SA node and the AV node, which are responsible for the pacing, what kind of issues that would cause if that's not getting perfused? Huh?
You got 18 now?
I want to say yes. But again, we're going to put a pin in that. Huh? Yeah. So heart blocks, we talked about those, and I'm sure Showalter said she's going to talk about all the dysrhythmias later at 4. That's the Mobitz 1, Mobitz 2, all those different heart blocks, 3rd degree, 1st degree. Another one is Brady dysrhythmias, like bradycardia. And that would make sense, if the SA node, which needs perfusion like anything else, is getting a decreased perfusion, it's probably not going to be able to pace as fast, so it's going to be slower. Brady dysrhythmias. Clear as mud? Yeah. Did they talk about the circumflex artery in yours too, or just the?
A little bit, but not really.
Yeah, it's not as, I don't want to say it's not as important, but it's not as important. Yeah, the circumflex artery, I'll just draw it real quick. So, you got your aorta, right? And it branches off into the right side, it branches off into the left side, and also like this one branches off into 2, and it's gonna be kind of hard to, that means it's going behind the heart, the little dotted line. So it wraps around, they call it circumflex because it like goes around the back side of the heart. Does that make sense? So that one does the posterior side of the heart, so that'd be a posterior MI. And it kind of just does some random things like lateral posterior wall and some of the SA/AV nodes. That's kind of all that I have written down on my notes. I don't know if you guys have anything specific for the circumflex. No, yeah, so I would focus most of your attentions on these two. This one's going to be more right-sided, this one's going to be left-sided. Expect to know, VTAC, Vfib for this side and possibly a. Yeah, just know, like if they say like, is it going to be between VTAC, Vfib, and like heart blocks and bradycardia, knowing which ones go with which. Does that make sense? Pretty clear on this one? Yeah. Is it okay to erase this, or does anybody need a picture of it or anything? Okay. Do you guys have any specific questions over any of the core pulmonale or infarct locations before we move on to anything? Nothing I missed in your notes? If you do, don't hesitate to ask. That's what this is for.
So you were talking about like the lines, like, are you gonna go into like what we're gonna do about it, or?
Yeah, I can. I didn't know specifically what you guys wanted me to focus on. I was trying to stick with what Dr. Hugh said to make sure I emphasize, because she's not going to do another review. But do you have a specific question? Oh, there's this one acronym. I don't know if you guys have heard it. That's super helpful with like signs and symptoms of MI. Have you guys heard Define Dad?
Mm-mm.
Okay. Find Dad, and it's kind of, I mean, it's not funny because it's horrible, but like,
Because you remember those. You
It's-
remember things like that.
it's just like find Dad because he fell out, and usually it's the dads that have the heart attack. So it's like, where can we find Dad? Anyway, but it's kind of horrible, but it's still funny. Okay, so the F stands for fever, and be like, well, what does that have to do with anything? It's actually people can strike a fever up to like 102 degrees, and as a response to like the decaying and the necrosis of the heart tissue. So your body just responds in that way. Another one is this feeling of impending doom. This is also, people feel this also when they're having like a pulmonary embolism too. It's just kind of like that blockage feeling, like you can't, like you're not getting the blood flow. It's just for some reason it makes you feel like, you just feel like something horrible is going to happen. Nausea, dyspnea, diaphoresis, anxiety, that kind of goes along with the impending doom. And what do you think the last one is? Okay, well, it's not that morbid. You mentioned it, I think, with when I asked what happens in the left ventricle when you block the LAD. Dysrhythmias. So all of those are some signs and symptoms of someone like presenting with a heart attack, and you're like, hey, what's happening to you? And they're having all these things. Pretty good indicator they're having an MI. Now women, on the other hand, don't fit into the find dad because it would be find mom, but there's not a find mom acronym that I'm aware of. But women tend to have more atypical presentations. Women tend to have atypical symptoms, like they'll have like the neck pain and like abdominal pain, or like between the shoulder blades pain, which is different than the normal like jaw and arm pain that most people think of when they think of a heart attack. They also, women tend to waveforms. What kind of waveforms do you typically see in women? STEMI or non-STEMI? Non-STEMI. For whatever reason, women tend to present with non-STEMI, so it gets missed sometimes. Like they're like, oh, I have abdominal pain, and they check an EKG and there's not ST elevation, so they think, oh, she's fine. But in reality, like she's actually just having atypical presentations. So women are interesting. I had another student in one of the previous ASAPs. She says, it's because women are silent sufferers. I thought that was pretty funny. Yeah, so NSTEMI is a big one. A lot of women don't have ST elevation for whatever reason. You guys need this still, or can I erase it?
So the atypical symptom for women was abdominal pain, neck pain.
Yeah, like between the shoulder blades. It's just kind of like things you wouldn't think that are like heart attack related. Like everyone knows like the main typical like signs of heart attack. Like in the movies they're like but it's like those are typically men. Women can, but they sometimes have atypical presentations. So let's see what else we got in here. What kind of, someone's having an MI, what kind of medical treatments, medications are you going to want to give them?
Nitro, morphine.
Which one do you want to start with, nitro or morphine? Why? Morphine is also a vasodilator. I was just wondering if you guys knew why you start with nitro instead of morphine.
Depression, like stronger.
Well, there's a couple of reasons. One of them, I don't know if you remember from learning about angina, is angina is relieved by nitro, and whereas like a heart attack really isn't, so much. So it's like you don't know if someone's coming in with chest pain related to it being an actual MI or if it's just angina, right? So you start with nitro first, and if it relieves it, then great, wonderful, right? If not, then we know, okay, this isn't angina, we're dealing with an MI, and you're going to give morphine. And this probably isn't a test reason, but a real life reason is a lot of people will come into the ER, oh, I have chest pain because they want morphine, because they're like drug seeking. So start with nitro, and that doesn't do anything for them. So that's not going to be on the test, but like I'm just telling you for real life. Oh, I have chest pain, I want morphine, it's allotted. Yeah.
There's some like.
Yeah, and that doesn't help them at all. It actually might give you a headache because you get nitro headaches. So,
Treatment for any MI.
huh?
You said this is treatment for MI?
Yeah.
Any, okay.
Yeah. Let's see. And this is where like in my notes where I had to find dad, and the last one was the dysrhythmias, where like I have the note saying like new onset of AFib, right? So yes, that is a symptom of having an MI. We just need to find out which which type, because there was the several. Okay.
Also aspirin, right? Aspirin.
ASA. What are some, I can't erase this. What are some lab tests that you're gonna get? What else? Was there, I don't know if in your notes or not, they mentioned myoglobin. Okay, well, I can just write it down, but, and what was the other one that you said? BNP, yeah.
I don't know the dimer. Oh,
These are the main ones. So troponins, these are going to be the best indicator of whether or not someone's having a heart attack. The other ones can be helpful, but this one is the best indicator because the heart muscle, there's, we have different types of muscle. We've got skeletal muscle, smooth muscle, and cardiac muscle, right? That's way back to your anatomy and physiology, right? Like intestines are smooth, your leg muscles are skeletal and your heart muscle. So troponins are unique to heart muscle. So whenever your heart is having an injury, like some of those proteins will enter into the bloodstream. And so if you see a rise in the troponin level, you know that specifically your heart muscle is in distress and that protein is spilling into the blood. And then this is the one where typically you'll also see the ST elevation along if you have elevated troponins. CKMB stands for creatine kinase, and I'm not sure what the MB stands for, but there's 3 different types of, these are becoming more specialized. So they have 3 types. There's CKMB, CKMM, and CKBB, because this is, again, like you've got different types of muscle. So the MB is specific to the heart. MM is more just like generic skeletal muscles, and BB is more for the brain. So if you can get it, like that's why they have it specifically a CKMB, not just a creatine kinase, because if you had just a creatine kinase, you wouldn't know if it's damaged to this, or this. Does that make sense? And then myoglobin, they probably didn't mention it to you in your, because they hardly ever use it, because this one's very unspecific. This one's just like muscle in general. And a lot of times this can be a result of like trauma, like someone like got in a really bad car accident and had a lot of like, their muscles got messed up. And so that doesn't really tell you a lot about the heart, but you can measure it in pee as well. So if it's like a urine test, it'll come up. It's damaging to the kidneys. So I guess it is good to like test to make sure, because it can clog up the kidneys and like, make and not have it filter through. So, but this one isn't used nearly as much as troponins. And BNP, what do you guys know about BNP?
Just like the stretching of the heart.
Yes. So where's my note on that? Yeah, so this is especially, you'll see this especially with like CHF. In CHF, it's kind of similar presenting factors with the right-sided heart failure, that the left-sided ventricle starts to stretch from the fluid overload. And then when the heart is like in distress and it just like, hey, we're done, it starts releasing BNP into the body. And when you measure that, that's generally not a good indicator for the longevity of your heart there. So it's kind of like, well, all right. Unfortunately, like once a heart has been kind of stretched out and damaged, it doesn't go back, doesn't go back to normal. I had something written down about this. Let's see if I can find it from a couple weeks ago. It's here. No, not that one. No. Let me see. Okay, here we go. This is released when the ventricles are like, I don't know what else to say, but dying or like in distress. BNP is actually useful in the sense that it's a hormone. It stands for what is it?
Brain natriuretic
Peptide, yeah. So the heart does a lot of like compensatory mechanisms to make up for the fact that it's not getting the good enough cardiac output. And when it gets to the point where like the ventricles are just kind of done, BNP will start being released, which is actually a helpful compensatory mechanism, because this one does the opposite of all of the constriction and everything, which is like damaging to the heart. So this one is actually a vasodilator, which is helpful to give the heart a break. Diuretic to get some of that fluid off. So it's helpful to the heart, but it's also a poor prognostic indicator of how well your heart is doing. If it's gotten to the point where it's releasing this now, your heart's in bad shape, if that makes sense. We also have synthetic BNP in drug form that we can give patients that are in heart failure to kind of help them out. But I don't know if that's in your notes, but it's just fun fact. It's called Nature Core. Ever heard of it? No? Okay. Well, don't have to worry about it then. Any questions about BNP? No. That one. Who's going to be around for Showalter's? Most of you guys. Okay. So what would you guys like to focus on now? I have notes on murmurs, endocarditis, pericarditis, myocarditis, rheumatic fever, thoracic aortic aneurysm, angina. I'm not going to do the dysrhythmias because she's going to do that one. So I'll put that aside. Huh? All of it? Okay. I just wanted to ask if there's a specific one. Huh?
Thoracic.
We'll do this. We'll do the whole thing I just said. We have plenty of time. I just didn't know if there's like a specific one. You were like, I need this. Okay. Okay. Let's start with murmurs. All right, when you listen for a murmur, which part of your stethoscope are you going to use? Why? Yes. So the flat, I don't know what you call it, the flat side of the stethoscope, the normal side is better to hear like higher pitched things. So like hyperactive vowel sounds are really great, like high pitched lung sounds, but like the low, what is this? Lower pitch sounds like lower vowel sounds or things like murmurs, those are best heard with the bell because it can pick those up better. So we're going to listen to the bell of the stethoscope. And then how are you going to position the patient? Right, so like roll them to their left, right? And that just, for whatever reason, that just positions the heart in such a way where you can hear the murmurs better. Okay, so if you hear an S3 sound, at what point in, the heart beating are you going to hear it? Yes, so it would sound like lub, dub, and then you'd hear the top, the S3 sound, so lub, dub, top. They also, this one is caused, what is this caused by? When someone has an S3, what's the reason? What was it?
Resistant ventricle defibrillator.
Right, so fluid overload, right? So that's typically with the left-sided heart failure, the congestive heart failure. So we'll put CHF, fluid overload. So I saw on your study guide about this is like knowing which sounds to expect for different prognoses. And so an S3 heart murmur would be something you would expect for someone with CHF or fluid overload and that sort of thing.
Left-sided heart failure or right-sided heart failure?
Well, congestive is usually because of the left side. Yeah, and like you said, whoever said it was, you'll hear at the end. So lub dub ta, you'll hear like that little like sound at the end. The S4. What do you know about S4? What was it?
It comes before S1.
Yeah, which is weird, right? Because it's like 4, 1, 2, 3. So this would be 1, lub, dub would be, S1, S2, and then this would be the S3, and then the S4 would come here, so you would hear ta, lub, dub. And I guess it kind of makes sense because like your heart, it goes in like a circular pattern, so I guess it doesn't really, I guess you could technically say it happens after S3 because it would also still be before S1. You know what I mean? Because it's a circle.
I have a question. The way to differentiate it is like the S4, it's like faster, right? It's like faster.
You don't have a way to let us listen to these.
YouTube. You can go on YouTube and listen. Like there's usually like a pause in between the heartbeat. Lub dub, pause, lub dub, pause, And so like after the pause and before you have the lub dub again, you'll hear the ta, lub dub, instead of lub dub ta, lub dub ta. Does that make sense?
Yeah.
So the pause, I guess that's why they say it's before. It's like there's like the pause after, then there's the pause after here. If that makes sense.
But there's like no pause between the ta and the love.
No, because it's before it goes ta lub dub, ta lub dub, ta lub dub versus lub dub ta, lub dub ta. I feel really weird saying this. What did she say?
There's a lot
Wait.
of really good YouTube videos on like the difference between them.
Yeah, you should share that with them.
I already left under the S3.
Okay, yeah, okay, here, I forgot to mention that. So something happens with this one. Okay, this one you'll hear is a cause of hypertrophy. So when the ventricle, that's not how you spell it. When the ventricles start, enlarging because they're trying to build up the muscle to squeeze out, you'll hear the S4. Now something happens, I forget what it's the nursey way to call it, but like, let's see if I can draw this. So this is your heart and this are the ventricles, and then like hypertrophy is happening. So the muscles don't just thicken outward, but they also like kind of thicken inwards as well. Like this is the heart muscle and then this is like the valve. So like the more it hypertrophies, like it makes the area smaller inside where you can actually have blood to fill, if that makes sense, which is part of the reason why cardiac output is so low, because there's like not enough space in here for blood anymore, because it's getting bigger outwards and inwards. Does that make sense? And so as the heart like grows, it kind of displaces the what is it, the PMI, the point of maximal impulse inducing. Sorry, it's been a minute since I was in nursing school. And so it's usually like it'd be like right here, and then as the heart grows and goes, it's gonna like shift this way, right? So like I forget how they word it, but like the PMI will start to shift in that direction. So you'll have to like shift your stethoscope a little bit more to hear it, if that makes sense, because the heart's growing that way. Does that make sense?
So that on the mitral area or the tricuspid area?
Okay, so you tell me which is which? Which one is this one and which one is this?
Right is mitral. Isn't it?
Yeah, so this always confused me because the mitral is also called the bicuspid.
Mhm.
So tricuspid and then
Tries
bicuspid
on the right.
/ mitral.
Try to get it right.
Try
Well,
before you buy.
Yeah. So this, I always thought, oh, well, 2 comes before 3, so it should be 2, 3. It's like, no, that's not it. And I always remember, like, when you go to the store, you try something on before you buy it, right? So try before you buy, if that makes sense.
I learned it as try to get it right. Try to get your question right. Or try
Whatever
it
works
right.
for you. That's just what stuck with me, was try before you buy.
I'm sorry to steal your punchline.
No, it's good. I don't mind. I didn't come up with it, so I don't get credit for it anyway. A lot of this stuff I didn't come up with, I just remember. Does that help? Let's see what
So
else.
S3 was try? Or no?
Would you listen to, where would you listen to it to hear it?
And the apex of PMI, like the point of maximal impulse. That's why like when it starts shifting, like you're gonna have to like
Just look for it, right?
just look for it. I mean, honestly, there's the textbook, but then there's real life. Like people have all sorts of weird anatomy. Like people with bigger breasts, men and women, you have to like kind of shift things around and like folds and all sorts of stuff. So it's like you got to just kind of hear it where you can hear it sometimes. Not everyone has like a perfect anatomy. Yeah.
How often do you get people where everything in their like abdomen is like their organs are split?
How often? I've never, but I mean, hopefully that's not super common in people. Yeah. Is this good? I'm gonna erase it now. We're gonna go into the itises, endocarditis and all those things. Is this good? Can I erase? That is not the correct time. Okay, I was very confused for a second. I was like, it's not 10 o'clock.
It's almost 1:48.
Thank you. Okay. This one. Did you guys ever in your notes for the test go over like mitral valve stenosis, tricuspid, or any of that, like regurgitation or stenosis at all? Okay.
You mentioned it. I think it was-
Okay, that's interesting. 'Cause we had like a whole section on that when I was. I was just wondering, because in my notes that comes before the endocarditis, so I was just wondering. I didn't want to skip it, but we'll skip it. Okay, so infective endocarditis. Okay. Let me draw another beautiful drawing. And yes, I know this isn't what the heart looks like, but for the sake of my drawing, this is what we're gonna go with. Okay. I need red. So I'm drawing the different layers of the heart because having a visual, I feel like is helpful when learning about where the different itises are happening. That makes sense. I'm a visual person. I don't know about you, but like if I can see it, it makes more sense to me. Okay, and one more. This is fluid, so this is supposed to be like waves. Just go with it. And then last one. Okay. Isn't this beautiful? Okay. Actually, it didn't turn out too bad. Okay, so this inner lining here, this innermost lining here, what is this one? Right, so this is the endocardium. Endo meaning like inner, endocardium. And this encompasses like the chambers and the valves, all of that's considered the endocardium. Good? This red layer, what's this red layer? This is the muscle, the heart muscle itself. So this is what gets hypertrophied, right? It starts growing and bulging out. So this is the myocardium. What is responsible for pumping and what dobutamine will help to pump and everything like that. Then we have the layer just outside of the myocardium. Do we know what that one is? Nope, this is the epicardium. And then here we have a fluid space, and this is what you call the pericardial space. Pericardial space. Now this is useful because as you can imagine, like your heart never stops beating throughout your entire life, hopefully, right? And so like that can build up a lot of like friction, you know, and heat when something's constantly moving, you know, like if you rub your hands together, like it builds up friction. So this fluid layer helps to like lubricate and reduce the friction of the heart because, you know, the heart muscle. Stop calling me. It's this telemarketer that keeps calling. It reduces the friction and lubricates the muscle that it's constantly like pumping. So it doesn't like, so these different layers don't like rub together and get like hot and like, you know, because if you didn't have any fluid here, the heart's just pumping, all these different layers are going to rub together and start having a lot of friction. And then here, someone said it was the last one. Pericardium. Yeah, so this is the pericardium. You can also hear it called the pericardial sac too. So it's just the sac that's holding the fluid in, right? So that's what that does. Is that kind of a helpful visual? So now when we're talking about infective endocarditis, you can understand that it's related to inflammation. That's what itis is always inflammation due to some kind of infectious organism that affects the chambers and the valves of the heart. So what are some risk factors that make someone more likely to get endocarditis? Yeah, IV drug use is the big one. So this is not how it always should be, but if someone comes into the ER with endocarditis, the first thing you think is IV drug use, which isn't necessarily always fair because not everyone who has endocarditis has been an IV drug user. It's just really happens to be one of the main reasons, especially in Chattanooga, there's a lot of that. And you can kind of tell by looking.
They
Like,
have poor mental health.
yeah, that sounds bad, but like you can tell by looking at a patient, like if they're, an IV drug user, you just can. You start like developing a sense for that. So yeah, IV drugs for sure. I'll give you one for free. Advanced age pretty much is a risk factor for all of the heart things, right? So the older you get, if you can't think of one and it's like a short answer, advanced age is always going to be a right answer. A decreased immune system. So that's why it's not always, IV drugs, but like if someone has like a lot of autoimmune diseases or whatever, they're just predisposed to getting infections, endocarditis is likely to happen. What about, since this encompasses the chambers and the valves, can you think of anything related to valves that would pose a risk factor?
Like a valve replacement.
Yeah, someone has a prosthetic valve. And it's interesting, like sometimes like whenever someone has something prosthetic in their bodies, whether it be like metal or screws or whatever, it tends to be a spot that's more likely to develop an infection just because it's a foreign object and your body tends to like treat it as a foreign object. So sometimes it increases like the inflammatory response to that area, right? I was just in the hospital I wasn't in the hospital, but I went to the hospital with a patient that's had a right knee surgery like 7 times because she had a knee replacement and it just kept getting infected. So she had to keep having to have surgeries over and over again because she had like a fake knee in there. And so that's just, I don't know what it is, but your body tends to kind of congregate and create these areas around things that aren't your actual body. So prosthetic valves are a risk factor. Yes. So you can get damaged valves from rheumatic heart failure, but that's not the same thing as endocarditis necessarily. It's because endocarditis is like all of the chambers and the valves. Rheumatic fever can damage your valves. Does that make sense? That's different than calling it endocarditis, I guess. Yeah, poor dental health. And I'm not really exactly sure, but like they explained it that the mouth like it's just like they have a portal right to the heart right there. So like any like infection here could just has one quick stop to the heart right there. So if someone's at risk for endocarditis, they want to make sure they do prophylactic antibiotics before dental procedures because like they're messing around in there, they can dislodge some bacteria and send it straight to the heart. So yeah, that probably will be a test question. Yeah.
Yeah, I think that's what she was explaining, like with aspirin, like even though like it's not doable, if someone is
I can't, sorry, it's hard to hear.
like with like she was explaining that like with aspirin, if someone is having, I think she said chest pain or something, but they want them to like chew it right away, like if they have it at home, they can just give it because it goes straight to the heart.
Yeah.
It sounds very good.
Yeah, so I would make a note of the dental questions. I have like high confidence that would be a test question. And about taking the antibiotics beforehand, before you go get dental procedures, especially if you're at risk.
Yeah, she mentioned like dental stuff like 4 different times for endocarditis, so.
Yeah, so yeah, dental. Big letters, right? And a star. A lot of the times, like a lot of the signs and symptoms or risk factors are going to be similar for various things that like this because it's all like pretty close together. So really the key is to like look for the things that are different and focus on that, right? Because dental is not going to be on the other ones, right? Just for endocarditis. Does that make sense? Let's see. Okay, so for signs and symptoms, a lot of them are going to be the same, but anytime there's a problem with valves or the chambers, what might you hear? Murmur, right? Murmur. Since it's infective, fever, and just kind of all the things that go along with being sick. I don't have to write all those out. I feel like you would know, elevated white blood cells, all that stuff. Another interesting thing is something called the vegetative formation. Did you hear about that?
Yes.
The vegetative formation. So let's see. How can I draw this? Okay. Here's your chambers again. It's like, here's a valve. A vegetative formation, if you look at pictures like on Google, whatever, a lot of them look like little cauliflower. It's very weird. So this little cauliflower growing in your heart, this can be irritating. You know, blood cells can stick to it and cause problems. Now, it poses an even bigger problem. Let's say if one grows like right here, right? What kind of problems do you think that would cause? Yeah, like the blood is gonna have a hard time getting through, right? Huh? Yeah, it could, that, you know, you're gonna have fluid buildup, block up, and you're like, oh, well, again, that's why when you treat heart failure, you have to know what's causing it first, right? Is it hypertension that's causing it first? Like, what's going on? Like, there's at different points, you could be having a problem getting rid of the fluid. Like, is it because of the left ventricle? Is it because of the hypertension in the lungs? Like, is it because a valve is damaged and like the fluid, there's nothing wrong with the heart, but the fluid just can't get through the valves, right? Or is there a growth happening that's blocking the valves? You know, or is you have really bad hypertension that can't overcome the hypertension in the aorta? So it's like how you treat it depends on like what the cause is. Right? Because there's so many different reasons why you could have fluid overload or heart failure. Does that make sense? So knowing the causes is a big one.
I have a question. Is that something you could see with like an echo?
Yeah, with an echo, you'd be able to see that. I don't know. I like to think of an X-ray and an echo is like taking a picture versus taking a video. So like there are certain things that you won't be able to know just from an X-ray, right? Like an X-ray is just like you take a quick picture, and so you can see, you'll be able to see stuff like hypertrophy in a picture. You could see that the heart's grown bigger. You could see, you know, you could possibly see, depending on like where it was, you could probably see a vegetative formation. You could see, you know, something like cardiac tamponade or whatever from a picture, but certain things need to have a video, right? Like seeing the valves, how they're working, because you know if they're regurging or if stuff is not getting through, because you'd have to watch the valves do their thing. So that's would be good for an echo. Or seeing how calculating how much someone's cardiac output is by watching how much the heart is squeezing and pumping out. That'll be good from an echo. Does that kind of make sense? An echo is basically like an ultrasound when you're looking at your baby, except on your heart. I mean, it's a little different, but it's essentially the idea. All right, what else? Blah, 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 blah. Okay, diagnosis. How are you gonna diagnose this?
Blood cultures.
Yes, big one. Blood cultures. If you have blood in your blood, now if you have culture, if you have antibiotics that are growing, or if you have, I cannot talk. If you have bacteria that are growing in your blood, we've got problems, right? And you'd expect to see that with endocarditis because it's literally like in the heart itself where all the blood is going. So blood cultures would be very helpful. An echocardiogram, the diagnostics, and hearing a murmur that can tell you, you know, if your valves are getting irritated or if the chambers themselves are getting irritated because of the inflammation. Inflammation always jacks everything up. So inflammation will make it hard to pump. It'll make the valves irritated. Okay, cool. What about treatments?
So would this be like isolation for the front murmurs?
Whoa, sorry, what?
The front murmurs would be like S3 or S4.
My notes didn't specify. Did yours specify? Let's see. Let me think about
Just
this.
says a new murmur or a worsening murmur. Is what I would say.
Yeah, if it doesn't specify, I wouldn't worry about it. That's just kind of where I'm at with that. Yeah, I'm not sure, to be honest. Does someone else have a question? I heard like 3 people ask something all at once. No?
Also, let's just use the text with that. This is an Vfib.
That's interesting. Well, for sake of that, perfect. You know, for the test, did everyone hear the answer?
So Vfib does.
Yeah.
For the
I asked her-
anterior.
I asked her the conclusion whether the movement of the LED in an anterior MI causes what type of arrhythmia. He said AFib, SVT, VTAC, and Vfib.
That's so interesting. Like I know the SVT. Cool. Only matters for your test. So there you go. All right, treatments. How would we treat this? It's an infection. So what's the obvious?
So diagnostics, only blood cultures there,
Oh,
or you're
sorry.
gonna put something else?
Sorry, I said it but didn't write it down.
Okay, they actually in the X-ray also?
Yeah, you can. I feel like echo would probably just be more useful.
Yeah, okay.
You know, Treatments, you said antibiotics, that's a big one, obviously. What else? What else do you want to put this person on? Probably for anticoagulants, you said that. Great job. So anticoagulants, again, anytime you're having an issue with the blood coming out well and there's being inflammation always causes, the immune system to respond, like histamines and clotting. So clotting can be an issue. So anticoagulants will help reduce any clots being spit out. Now, what happens if you have one of these guys? What are you gonna do about that? Surgery. So sometimes you might need surgery if a valve gets permanently damaged and you can't fix that with medication.
You have to replace it all.
Yeah. And then if you get a valve replacement, it might put you at risk for having it anyways. So yeah. So so surgery might be necessary if you do have vegetative formations, or if a valve needs to be replaced, or if there's an abscess inside the heart, which is more common with IV drug use. Abscesses are like I don't understand, but like abscesses form kind of everywhere on people who have IV drug use. I don't really know why, the patho behind that, but it's kind of one of those things where you can take a look and you just see kind of like abscesses all over their face. You're like, so you've never done drugs in your life, okay? Like, yeah. Okay, any questions about endocarditis? No? Should we do pericarditis?
Sure.
Not trying.
With the heart rhythms, I know Showalter's doing them afterwards. But if we have time, can you glance at them? If you have easy ways that you remember them, or
I do have one thing that might be helpful for the heart blocks. So if we have time, I'll do that one.
Okay.
But I feel like she said specifically she's gonna go over dysrhythmias. So I don't want to like do it and then her do it and then it'd be a lot. So, okay, let me erase this one.
Also, if you have your like notes from last semester, Professor Hughes like really goes in depth with all of them.
I didn't understand it last semester, don't understand.
Oh, that was good. Okay, now pericarditis. Okay, let's look at my drawing. My beautiful thing that needs to be framed. Clearly was an art major. Okay, so which layer are we looking at that's going to be inflamed? This one, right? So just using your critical thinking hats, if this sac gets really inflamed, what kind of problems do you think that's going to cause? Well, yes, I'm just saying if the sac is inflamed, it's the outermost layer, right? Everything else is in the heart's going to get squished, right? Because it's like inflammation causes like swelling, right? So if I'm the pericardium and I'm squeezing the heart, like it's going to start squeezing it more, putting all this pressure on the heart, and it's going to make this fluid layer a lot smaller because it's kind of squishing it, right? So then one of the things you might hear when you listen to the heart will be what?
the friction rub.
The friction rub, right? And anyone know what that sounds like? Have you ever heard one? Yeah, this might be a weird analogy, but anybody here ride horses? You ever hear like the sound of like the saddle that it makes when it's like squeaking? It's like, it's kind of like that weird, like leathery, rubbery sound. That's what a friction rub sounds like. And that makes sense if you think about it this way, like this layer here is getting squeezed and tightened. And so these layers, as they get inflamed, are going to get closer and closer together, right? And so they're going to start rubbing as they're pumping. You're going to hear the because there's not this big fluid layer there anymore. Does that make sense? Mm-hmm. So friction rub, you might hear that. We not skip risk factors. What are some risk factors can you think of? That's going to be probably a risk factor for everything. I guess specifically to this one that's different than others would be like anything that's a chronic source of inflammation. Because that's inflammatory markers in the body is never helpful. It's always bad. So like people that have like radiation or chemo or cancers like that, where their body's constantly like in state of inflammation, are at risk for pericarditis. What are some other ones that you guys have?
Like short term or long term?
I think she said to focus on acute.
Did she?
Yeah.
Focus on the what?
The more acute version?
Acute.
Yeah.
So like MI, trauma.
Trauma, bacteria, pest.
Yeah.
cabbage.
Well, bacteria goes with inflammation. And then surgery, post-cabbage, that goes with inflammation because you just had surgery. So chronic inflammation will help cover a lot of those because the pericardium is becoming inflamed. So it's responding that way. So we mentioned the friction rub. Does that make sense? Why you would hear that? So I don't want you to forget that one. Let's see, what other signs and symptoms? What do we expect to see with inflammation is normal signs and symptoms?
Red blood cells, fever.
All those things. What else? Pleuritic chest pain. You know what that is? So what's the difference between regular chest pain and pleuritic chest pain?
You can hold your breath and you can feel no difference, right? Is that? No,
Yeah,
that's-
pleuritic chest pain has, again, this has to do with lungs, like, so it's related to like breathing, the chest pain. So like chest pain in general is just, it just hurts, like regardless of what you're doing. Pleuritic chest pain is like hurting when you're breathing, right? And if you think about the pressure, right? When you breathe in, suddenly you have a lot more pressure in your lungs, and the lungs are gonna be, putting pressure around the other organs, pressing on the heart even more, and it's already inflamed. So it's like you're building the pressure every time you breathe. Does that make sense? So it hurts more when you breathe, because breathe in, suddenly you have all this like more volume inside your chest cavity, and your heart's in there too. So it's like even more squished every time you breathe, if that makes sense. So breathing, what's something else that you might do that would increase the pain, increasing pressure? Coughing. Yeah, so when you cough, I don't know if you've ever like coughed right after doing like an ab workout, but your abs hurt when you cough because it's like you're tensing those muscles and like putting pressure. And so like it does the same thing. I was like, when you breathe in, the coughing puts pressure on that heart. So that would be breathing, coughing, swallowing. Swallowing does the same thing. So if you see that on a test where it talks about like, specifically chest pain related to any of these things, you think that. Breathing, coughing, swallowing. Does that make sense? How it's different than regular chest pain?
I guess a way to remember is like peri or plural, like.
Sorry?
I guess a way to remember is like peri, like plural.
The two P's?
Yeah.
Yeah. Well, you can just think pressure too, which is another P. Pressure. The big one is the friction rub. I guarantee that'll be on there somewhere. Let's see. Oh, where would you hear a friction rub?
Like the heart lung area?
Yeah, so yep, left lower sternal border. All right, left. This marker is dying. Left lower sternal border. So that's where you would hear it, and you can hear it best at the end of expiration. So like as they're breathing out, you'll hear like as they're exhaling. I've heard it not very often, but I've heard it maybe once or twice. It sounds so weird. It literally sounds like the creaking of a saddle as you're riding a horse. So end of expiration. Got that? And that, kind of makes sense because, after you breathe out, it's more quiet, and you can hear the That's what it sounds like. Okay. What else? How would you diagnose this?
An EKG?
Yeah, what about an EKG? What's that gonna tell you? Right, so the heart, it's really hard to write under here. ST elevation. So don't automatically think MI just when you see ST elevation. It's really just like your heart is in distress, right? And you got all that pressure pressing on that heart. It's going to cause the heart to make those ST elevations. And I don't know if I can draw an ST elevation, but I'm gonna try it. So P wave, Q, R, and then the S doesn't come all the way down. Because this is like the baseline. So this is what ST elevation looks like, right? Something like that. Probably a little bit prettier. Okay, so if inflammation is the problem, what kind of treatments can we give? Why? Because it's called a anti-inflammatory, right? So that's right up in the answer. So NSAIDs are very helpful, anti-inflammatories. What else? What are stronger?
Steroids.
Right, so non-steroidals, and if that doesn't work, then we go to steroidals, right? So NSAIDs are just not as strong and taxing to the immune system, and then steroids are just a bump up if that doesn't work. Steroids also decrease your immune systems, which is why they try to not start with that, right? What else can we give them? Yeah, antibiotics. Any more questions about this one?
She specifically said just the positioning, sitting them up and leaning them forward.
Oh,
helps
that's right.
with this.
Oh, yes, yes. That's good. Setting them up. I'm trying to think if there's anything I missed on this one.
Oh, the cardiac.
What was that?
Cardiac tamponade.
Oh, yes.
Pericarditis.
Okay, so that's right. Just about to reach that point. Okay, so cardiac tamponade. It's kind of, I don't actually know the real reason, but I'm going to tell you what makes sense to me in my mind to explain why it causes cardiac tamponade, but I don't know if it's actually true, but it just makes sense to me. So you know how like I said that this is getting inflamed and the friction rub happens and it's like these two layers like grinding together and the fluid like hasn't had enough space. So in my mind, if I'm the heart, I'm like, oh, we're having all this friction. We should create more fluid to fix the problem, right? So like help lubricate it better. So we're going to increase more fluid, right? And so that might help with the lubricating. But now you have like even more fluid production, which water has weight. So it's even more weight on top of the heart, which is even more of a stress. Does that make sense? So that's just in my mind how it makes sense to me to tie the tamponade with the pericarditis, because otherwise I couldn't remember it. Do you have a question?
Yeah, I have a question. So one of the lectures, I forgot which one, she said for next triad, like the sign and symptoms of cardiac tamponade or whatever, she said low blood pressure, but in another one, she also said like it gets systolic and diastolic gets closer together because it's like not stretching out, so it causes them to become like more equal.
Yeah,
Okay.
so like, I think she mentioned like the below blood pressure, it would still be lower, like, it would be like 80
Yeah.
over 60 or something like
But it
that.
would be like systolic and diastolic.
Yeah, she said within like 20 millimeters of mercury.
So cardiac tamponade. Sorry to the men in the room, but also I can remember the fluid accumulating because it has tampon in there. You know, it sucks up fluid. That's how I remember that as well. How do you fix tamponade? What can you do? What is that exactly? Yeah, this sounds very not fun to me. I don't want this to ever happen because I don't like needles, let alone going into my heart. So needle literally goes into here into the pericardial space and literally has to just like suck the fluid out. So that's a fun procedure, but that's what that is. I don't know if there's anything else you need to know about tamponade other than those couple things. Are you raising your hand or stretching?
Go through the pleuritic chest pain.
The pleuritic chest pain?
Yeah, sorry.
Yeah, so you'll feel the chest, you'll feel the pain in your heart and your chest when breathing, coughing, or swallowing, because all these three things increase the pressure in your chest cavity. So like when you breathe in, you're stuffing more volume into your chest. It's like blowing up a balloon, you know, into your lungs. And so that presses against the heart. And so it's just adding more pressure on top of it's already being under pressure. Coughing, you know, causes pressure, and swallowing for whatever reason, you swallow and it causes pressure.
And not, you don't have pleuritic chest pain with the other itises, or do you also have it?
No, because this one is just related to like the whole heart is like the whole outer level of the heart is inflamed. Whereas with endocarditis, it's just a swelling of like the individual chamber or the valves. So you shouldn't have, yeah, for sure. Like you'll have chest pain pretty much with every heart problem, but pleuritic chest pain is specific because it's like has to do with like pressure when you breathe in and things like that. Are we good on this one? You think so? You guys have like the dead eyes. Sorry. So funny. Okay, let me just make sure.
Might come back to life after the test tomorrow or die.
I know that the notes are very similar from, I asked her, like, 'cause I have my notes from when I took the class. I know they might just be a little bit different, which is why I always ask, like, what yours say. Just to make sure I'm not telling you something that's different that they've changed, because sometimes I'll have like updates and medical stuff and then it changes. Okay, so that was pericarditis. Okay, the next one on my list I have is myocarditis, and then we'll do the rheumatic. Let's do that. Erase this one. Is this helpful?
Yes.
Okay, I can't tell sometimes by the blank expressions, and I think it's just because you're tired and not because I'm terrible at explaining. Oh yeah, that too.
Is there a way to turn up the temperature?
I'm sorry?
Is anyone else cold?
Yeah.
I was
Freezing.
freezing, but I
Yeah.
have no clue how to change that. I don't think I get paid enough to change the temperature.
Is there a thermostatic unit here?
I mean, maybe behind that.
Oh,
No.
Sorry.
Okay. Myocarditis. Wow. Okay. What are some risk factors for this one? Not a ton. There's just a few. I don't know. Yeah, viral things, viruses, and then also drug reactions. Is that on yours?
Yes.
Drug reactions. So, people can have a bad reaction to specific drugs or even vaccines or whatever and cause myocarditis. So signs and symptoms. And now what we're talking about right now is the red layer, right, which goes all the way around the heart. So you can imagine if the whole heart muscle is inflamed, that's probably not good, right? Like, because the heart is trying to pump, right? So that's generally bad. This would be different than, say, like hypertrophy, because inflammation does cause swelling and whatever, but hypertrophy is more localized to like the particular ventricle. So like it would be like a growing of like a particular spot here, not the whole entire heart, if that makes sense. So if you took an X-ray or an echo, you could differentiate between myocarditis versus like hypertrophy in that way. Okay, signs and symptoms. The whole heart muscle is irritated. And we want the heart muscles are responsible for pumping and making the the rhythms. So what do you expect to see as a side effect of having all of your heart muscle inflamed? Well, yes, chest pain, but what else? Dysrhythmias. And so, okay, this chest pain is just going to be generic chest pain, not pleuritic, because it has nothing to do with breathing. It's just like your heart just hurts, right, all the time. Chest pain, dysrhythmias. Can you guys read my handwriting? Okay. When you guys go into the real life, try to read doctor's handwriting. Good luck with that. That's the skill right there. Okay, chest pain. What's cardiac output gonna look like? This hint is for free. Cardiac output is always going to be low when there's cardiac issues. Okay, so other generic symptoms, feelings of like sick, like malaise, fever, headache, all those kind of just like not feeling well symptoms are going to go in there. Those really aren't super helpful specific. What do we worry about anytime that there's dysrhythmias? Clots, exactly. And what do clots lead to? Yes, depending on where the clot goes, right? So if the clot goes to the brain, it's a stroke. If it goes to the lungs, it's a pulmonary embolism. If it goes to the heart, it's an MI. So none of those things are good to have. So myocarditis, in and of itself isn't necessarily super dangerous because it can be resolved and usually goes away. But if it causes clots, you can have a stroke, heart attack, or die, or sudden death, right? So that's why myocarditis can be really scary, right? If you have dysrhythmias, because dysrhythmias lead to clots. So treatment for this, really, there's not like, there wasn't a ton in my notes. I don't know what you guys have. I mean, prevention was a big one on my notes, but I don't know what you guys have.
She said that infection with a virus actually causes it, so like vaccines and like avoid being around like people who are infected.
Yeah, so prevention really is just trying to not get sick, really. Hand hygiene, you know, that sort of thing. Any other questions about myocarditis? I feel like this one's the easy one out of all the others.
What's the, how do you diagnose it?
What do you guys have in your notes? I didn't have any.
Yeah, I don't have any.
Cool. Yeah, me neither.
I've never laughed.
That's great. I mean, I guess would probably, you know, like, yeah, to see the inflamed heart muscle. I mean, if you have all these other signs and symptoms, you probably have inflammatory markers in your lab tests. There, I don't know if there's something specific if she just didn't put it down. I don't know. If it's not in your notes, I mean, it can't be on the test, right? You said one. Okay, last one for the itises, well, it's not really an itis. Well, I guess it is rheumatic carditis or rheumatic heart failure or whatever you want to call it. Water. Okay. Rheumatic. So, okay. Now, what is the worry about rheumatic? What is your say? Rheumatic carditis, rheumatic heart failure? I don't want to just keep calling it a different thing. Okay. There's so many different things you can call it. Rheumatic heart disease. We'll call it that. Okay. The worry or the issue that we care about with this is having permanently damage to what?
The
Valves, right? So this is related to which diseases that you can get, which sicknesses. Yes, strep throat and scarlet fever. So if you get these, especially if you're young, like a child, you know, it's best to get it treated and get it taken care of because you don't want this, you know, strep throat's like right here, right? Again, it's like in the same mucous membrane area that can go straight to the heart, causing the endocarditis, right? So we don't want that. So fixing this is a big treatment or prevention. You know, like if you have this, go get it treated because it can damage the valves forever. And then you'll have to get surgery and have a prosthetic valve, and then that will set you up for being at risk for endocarditis. And so it's like a big circle, right? So it's not always drug users. It could be maybe the kid had strep throat as a kid, or a kid had strep throat and then they didn't get it treated, and then they got the valve issues, and it's just a big circle. So what do you expect to see signs and symptoms wise? I mean, typical sick, fever, all of that. Now this one's going to have specific signs and symptoms that are going to be different than the other ones. Are you guys familiar with rheumatoid arthritis? So this is kind of in line with that. So you'll expect to see things that are related to those kind of signs and symptoms. So painful joints, right? What else? Yeah, these are kind of just like really kind of weird signs and symptoms that you wouldn't think have anything to do with the heart specifically, right? But it's not technically, I guess, like just to the heart because it affects all of the different parts of the body. They're just mentioning it in the cardiac section because it does have cardiac effects with the valves. So it's not like just a heart thing. It affects like the rest of the body as well. I just think of rheumatoid arthritis, and that way I can remember like the joints and all the other things. And the scarlet fever makes you think of a rash because it's the same color and that sort of thing. The nodules are just like random like bumps under the skin. So these are definitely like unique signs and symptoms that you can remember that aren't going to apply to any of the other ones. So remembering like the different ones are really helpful, because fever, chest pain, shortness of breath, those are going to be all of them, right? So that doesn't help you differentiate between any of them. Is there anything else on this one that you guys had?
She told us to start shortness of breath, especially with activity or when laying down. So that results from the hardening of the arteries, and then chest pain and swelling.
Perfect. Yeah, I don't have any of that in my notes, so just the generic symptoms, you know. Let's see. Any other questions about any of the itises? How to differentiate or anything like that?
On my notes for pericarditis, just to how to identify the like, you know, if you ask for patient lower blood pressure and jugular vein extension. Oh, and by the way, just I have that also pericarditis related to hard-sided heart failure.
To which sided?
Right, I'm sorry, right.
The pericarditis?
Yeah.
Yeah, oh, muffled heart sounds for sure for tamponade, because you got all the fluid surrounding it, right? So it's like, you know, when you try to talk underwater, that's kind of a helpful analogy. You can't really hear it as well because it sounds get muffled underwater. So muffled heart sounds when you've got a ton of fluid surrounding the heart would be why.
And why the right-sided heart failure?
To be honest, I'm not sure. I don't have that in my notes. I think that might be something new. Does everyone has that too?
Because jugular vein extension.
It's
liver
related
vein
to-
enlargement.
Yeah, it's related
Okay.
to heart
Due to increased pressure is what I put.
Perfect. And that makes sense. Yeah, makes sense. What was that?
I was gonna say, I feel like that's for everything, right?
Yeah. Yeah, I mean, it is, right? Inflammation or like pressure buildup, it causes the fluid buildup. So fluid backflow is going to look the same regardless of what's causing it. It's just going to be the same result, right? So, yeah, I don't see anything else on here about those. Shall we do TAA?
Yeah.
Thoracic aortic aneurysm. I wish I had access to the specific notes that you guys have, but I feel like that'd be really helpful for me. You know,
The PowerPoint and the notes. I'm pretty the PowerPoints
Yeah.
too.
I'm gonna see if I can't like somehow get access to that, because I mean, most of the information I have is the same, you know, it doesn't like change drastically, but you know, there's little things like the AFib example that like might be a little bit different. I don't want to like, you know, be the reason someone got something wrong. All right, TAA or thoracic aortic aneurysm. Okay, so quick, I can actually erase this now. Goodbye. Who knows what an aneurysm actually is? Yeah, so it's helpful to know exactly what we're talking about. So like if let's say it's aortic, so this is your aorta and it just starts to get weak, so it starts kind of like pooching out and ballooning out, right? Because you know these walls should be thick and firm, but as they start getting weaker, they start to like balloon out and get stretched, which is not optimal because now it can't constrict and dilate normally, so the blood pressure is gonna be super weird. And eventually, you know, it'll burst. So dissection, there's two types. There's dissection and there's the rupture, right? So both of these are bad. You don't want either one. Dissection, let's see if I can explain this. So you know how, oh, I think that's now. Okay. So this is your blood vessel. You know, just like everywhere it has it has layers, right? You have the muscular layer, you got like the cellular epithelial layer or whatever. I'm not gonna go into all the layers because I don't remember, but it has several layers, right? So when a dissection happens, let's say there's a rupture in like one of the layers, right? So the blood that's normally inside where it's supposed to be can seep down into where it ruptured and like get in between the layers. And so you're not bleeding out yet, because that's a rupture, but you're working on a rupture, because like now that this layer is busted, it might move down to the next layer and the next layer until eventually it ruptures, right? So you have bleeding in between the layers. Does that make sense? So that's what a dissection is. Still not good because the blood isn't going to where it needs to go. And then also you can imagine that all this blood in between the layers where it's not supposed to be increases pressure, which stretches out the layer, which causes a rupture anyway. So dissections lead to ruptures, if that makes sense. Let's see. Okay, any risk factors that you guys know? Yeah. So hypertension, I think someone said, cholesterol, increased age, it's always going to be a risk factor. Now, hypertension, obviously, because hypertension is constantly putting pressure on the layers and it just weakens them over time. Because like, you know, anytime that you're like, if you take a rubber band and just pull it tight and you just keep pulling it tighter, it's gonna rupture, it's gonna break eventually, right? So same thing, cholesterol. Why do you think cholesterol would be a risk factor? Plaque buildup. So how can we draw this somewhere else? Okay, so if this is your vessel, you can get like plaque formations, right? And so that makes the blood have to go around, which can create turbulence, and like the blood is supposed to be like moving like linearly, like with the blood vessel. But if you've got all this turbulence and you've got like, you know, a bunch of plaque building up, the blood has to like move around and it's like slamming against the walls, and it's just turbulence against the inside of the vessels. But also these plaques can get dislodged and start floating around and like damaging the inside of the vessel, because they're not supposed to be there. So they can like damage the interior lining of the vessels. They can also cause just like a clot. If one ruptures and gets dislodged, it can go cause like a clot, just like a for an MI or anything like that, to get stuck and wedged in a smaller vessel and completely block it off. So cholesterol is not ever good. Let's see. Cholesterol. Do you have anything about Marfan's?
Yes.
Yeah.
Okay. What do you have about Marfan's?
She just said
It is
myself.
risk factor.
Okay. Marfan's. Cool. Don't know much about that. I just know that like you're super tall and you have like really big hands and things.
And the we breathe in.
Oh yeah, and the concave chest, right? Yeah. Yeah. It looks like a Martian, you know, because you're really tall and got big hands. That's not.
So do they just have like weaker vessels because of that?
It's probably some genetic thing where like it just manifests in different ways, and like one of the ways is that like the height and the concave chest and maybe just weaker vessels is part of that genetic predisposition. I don't know much about it, to be honest with you, but that's definitely on there. What else?
She also has atherosclerosis.
Yeah, that's basically this, you know, yeah, the hardening of the arteries due to cholesterol or hypertension. Both of these are related to atherosclerosis.
And you can see it on chest X-ray.
You what?
You can see it in an X-ray, like the enlarged aorta.
Oh yeah, you can see on a picture this balloony poochy thing. Okay, so signs and symptoms. You can probably imagine pain being one of them. Yeah, obviously. Interestingly enough, like a cough and hoarseness is common. I don't have an answer for that. I really don't know.
She says in cough is from like a pressure on the lungs, and then the hoarse voice is because it's affecting the laryngeal nerve.
The what?
Laryngeal nerve.
No. I don't know how a bursted aorta has to do with the
No, it
laryngeal
just
nerve.
puts pressure on it.
Yeah. Okay, sure, whatever helps you remember. Didn't know that. So cough, I know that that's a sign, I didn't know why that was. So cough. What was the other thing? Hoarseness. I almost spelled it like the animal. What else? Let's see. So treatment, really is if you can prevent most of these factors. You can't prevent having Marfan syndrome, but you
Oh, sorry.
Mhm.
This- I found like in red mine was like problems with swallowing. She started there, yeah. So it started
with Marfan's.
with the sinus symptoms.
Swallowing.
Oh, this one.
Yeah.
Okay, you said swallowing.
Yeah, swallow.
Perfect. Swallowing issues. Yeah, so treatment is largely preventative. You can prevent this, and this by lifestyle, like diet and things. The other thing is if you go in, they see that you're having a dissection or it's like pooched out like this, I mean, you're gonna have surgery to fix that. I've seen various things where you can reinforce it, like kind of like wrapping it in a sense, like, you kind of like wrap a binding around it or like cutting out the disease part and reattaching various different things. So yeah, aneurysms can be bad news. And you wanted specifically to talk about this one. Was there anything I missed, or was it you or her?
I told her to ask. 'cause
You told her,
when I
okay.
said it, so
Was this helpful, or I don't? Okay.
Yeah.
I don't know if there's anything else that was missing.
I haven't missed that day of class.
You missed the day. Okay.
Oh, wait, sorry. What was the treatment? It's just prevention?
Yeah, I mean, treat for prevention and surgery. There's not much else you can really do if someone has.
Just like a graft or something?
Yeah, like they can reinforce it around it if it hasn't quite ruptured, or like you can reattach the parts that aren't. Surgery is really the only option. Like, there's not much else you
If
can't.
it's already ruptured, then you're just gonna die.
I mean, it's not a great situation to be in. I guess it depends how fast they catch it.
I heard they usually do. if it's ruptured.
Yeah.
I know someone that had an aneurysm in their brain and they're still here. So, it just kind of depends.
And the brain is smaller, probably
Yeah.
smaller. Fast.
Yeah, I mean, this isn't a great situation, right? Because the aorta is what gets the blood to the whole body. So if that bursts, I mean, you're kind of out of luck, you know what I mean? Like, it's not like a smaller artery. I don't know what to tell you. Like, I imagine that there's been people that have had this that have survived. You know what I mean? There's got to be, but like, I don't know. I haven't done surgery on these, so I couldn't tell you. You probably don't want this to happen to you, is all I can say. All right, let's erase this. Okay. What time it is? Let me see.
2:42.
Okay. Do you want to do? We got about 15 minutes. Do you want to do stable, unstable angina, or do you want to do my heart block thing? Okay. All right. You feel good about angina?
Yeah.
Okay, basically nitro. If it fixes it, stable. If it doesn't, unstable. That's the short and long, the short version. Okay. So I used to have such a hard time with the heart blocks for whatever reason. I don't really know. So I'm just gonna go over those. Showalter's probably gonna go over them too. But I have like I don't know if you've heard this before, but if you have, I'm sorry, but it's kind of a way that I help me remember it. So we'll start with first degree heart block, and then we'll do second degree, which is the Mobitz 1 and the Mobitz 2, and then third degree. So we'll do 1, 2, which has the 1 and the 2, and then 3. Okay, so first degree heart block. To preface this, all of these kind of have like a similar story. So there's Mrs. P. This is Mrs. P. And she's married to Winky, which is the QRS. Okay, so this is Mr. Winky, and this is Mrs. P. All right, they're married. now over time, their marriage has had some troubles, and so now they're growing some distance between each other. They're not as close as they used to be. So there's now some growing distance between the P and the QRS, right? They used to be closer. Now they're getting, marital strife. So basically, first degree is the different stages of their marriage. Okay, so first degree is they're growing further apart, right? So the P is just getting further away from the QRS or from Winky. All right, and so that's always going to be the same. It's predictable. It's a pattern. So if you look at a strip, you'll always see that, right? It's consistent, right? The P distance, whatever it is going to be the same, but it's just going to be consistently further apart. Does that make sense? First degree. Okay. Second degree, there's two types, right? Mobitz 1 and Mobitz 2. So we'll start with Mobitz 1. Okay. So now Winky has started developing this pattern of behavior that Mrs. P does not appreciate. So Mrs. P, she's loyal, she shows up. Now, some time goes on and Winky decides to go out with his friends and comes home late, right? So that's what this distance is. Then, Mrs. P is waiting for him at home. Longer time goes on, Winky goes out with his friends and comes home even later, right? So it's shorter and then longer. I'm not doing it great to scale, but you can see this is shorter and then this is growing. So then Winky goes out with his friends and stays out so late, he doesn't even come home. So he's missing right here. Then Mrs. P wakes up the next morning, yells at him, gives him a piece of her mind, and now Winky back. Right? So this one's called Winky back. Right? So he came home late, came home later, didn't come home at all. She yelled at him, Winky back. Right? So it will always follow that pattern. So late, later, missing, and then repeat, right? So the P interval changes, but it's always the same, if that makes sense. Late, later, missing, because the Q should have been here. That's not what that looks like. It should have been here, right? But it didn't show up. So it was missing. So this was the one that wasn't there. So a dropped QRS is what you're looking for in the second degree, or sorry, the Mobitz 1 second degree, right? The Winky back. Does that make sense? Is that clear?
So the first one's just called the first degree.
Mm-hmm.
The second one is called a Mobitz 1.
First degree, and then there's two types of second degrry, right? There's Mobitz 1 and Mobitz 2.
Okay.
And Mobitz 1 is also called Winky back. That's why his name is Winky. Does that make sense? So you can see that their marriage is getting worse as time goes on, right? First they just had distance. Now he's like not coming home. So next we have Mobitz 2. And this one doesn't have a fun name. It's just Mobitz 2. Now Winky has just about had it with Mrs. P. He doesn't even care anymore what she says, but Mrs. P continues to be loyal. So she shows up the same. So how this one looks is that the PR interval, this thing, P to R, is always going to be the same because Mrs. P is always loyal. She's the committed one, right? It's Winky that's, kind of gone off the deep end and, forgot his marital vows and whatnot. So Mrs. P shows up every time. And sometimes Winky will do his thing and be the good husband and come. Other times he won't, just like he dropped here, so he'll be missing. So basically, how to keep drawing this is like he'll either be there sometimes or he won't, but there's no way to really tell when. So the PR interval is always going to be the same. Like the QRS should be right there. This is good. It's not the scale, but it should be the same. So the places where he just either doesn't come home at all. So basically what's happening is that the P interval, whenever there is one, whenever there is a full PQRS that happens, right there, the PR interval is always the same.
So the P wave is still marching.
Yes.
Same.
So with this one, it's very similar to this one, except if you just randomly took out some QRSs, if that makes sense. So if you had like a long strip of stage of heart block 1 first degree, and then you just randomly just kind of plucked out some QRSs at random, that would be this one, right? So it's the same thing, like the PR is always the same whenever they do have a PQRS. It's just that sometimes Winky just doesn't even show up because he doesn't feel like it. Does that make sense? No?
Yes.
Okay, I know that these suck. I had a hard time with these. So the way you can differentiate between this one and this one is that the PR will get progressively longer, drop, and then pick up again. Short, longer, missing, and then repeat. So it'll be that normal pattern. Whereas this one, it's like random whether or not the QRS will happen, but whenever it does happen, the PR interval is always the same because Mrs. P at this point is still committed and loyal and doing her part. Does that make sense? But you can see Winky's behavior is getting progressively worse as we go down. But first, we're just having some distance. Here, he still comes, and every once in a while he doesn't come back, but he always comes back. Winky comes back. This one, there's no predicting his behavior, whether he's going to be there or not, but P is still loyal. Does that make sense?
So for the first degree and then second type 1, there's elongation.
Yes, so the PR interval changes,
Yeah.
right? So shorter, longer, missing. That makes sense.
Yeah.
Does that make sense? Yeah. I know these are hard. And then the last one, this is the one is third degree. And this one is where both of them decide they've had it. Mrs. P's done, Winky's done, so they have an electrical divorce. Okay, so this one, electrical divorce. Unfortunately, they can't move out, so they have to continue living together, but they just do their own thing without any consideration or care of what the other is doing, right? So third degree rhythm is going to look a hot mess, and I'm going to try my best. So it's just completely random. So you'll have P, QRS, normal, P, P, P. I don't know, I'm just trying to make it really random. So there's like no anything working together. Like, does that make sense? Like everything is just random. So you can't actually measure a PR interval with this one because there really isn't one. Each one's going to be completely different. Yeah.
Is it like sometimes a beat is strong, but also there's elongation, so there's both?
There's just complete randomness, right? So like you can't, in this one, you cannot measure a PR interval, right? Because the PR interval implies that they're working together in some way, that the P goes and then that stimulates the QRS to respond, right? Whereas this one, the P is going, it's doing its thing, and the QRS is going and doing its own thing. So if it looks like there's a PR interval, like it's going to be completely different than what like another one might be because they're not actually going together. It's just both of them are just like doing their own thing at the same time, but there's no like rhyme or reason to it. So if you try to measure a PR interval and you measure this one, and you're like, oh, let's measure this one, let's measure this one, they're all going to be different. So does that make sense? They're all different, so you cannot measure a PR interval. And I'm just stuck on my little jacket thing here. Okay, so that's different than this one because yes, the PR interval changes, but it's in a pattern.
It's consistent.
Whereas this one, there's no pattern. It's like they're just living in the same house, doing their own thing, and sometimes they happen to intersect and collide with each other, but it's not on purpose. So if they mention anything about like not being able to measure a PR interval or the PR interval is always inconsistent, that's going to be third degree. Does that make sense? If they're talking about the P is still always consistent, but they just have dropped QRSs at random, that's second degree type 2, because the P is still trying to do her part, right? She's still trying to be consistent. And then Winky just decides to show up sometimes, not show up, not show up. But the PR interval, whenever there is one, is always the same, right? So this should be the same as this, which should be the same as that, which is it's not to scale because I don't have the grids, but I do my best. Does that help at all?
Yes.
Does that make sense? These were like so hard to me until like I heard this analogy. I can't take credit for it. I didn't make it up, but it was really helpful. So hopefully that helps. Now with third degree, this is the one where you're like, okay, you need a pacemaker, right? Because they're not working together at all, right? It's just the ventricles are going when they feel like it, and the atrium's going when they feel like it, and they're not doing it together in harmony, right? So it's just kind of a mess. So you need a pacemaker for this one. You also could use a pacemaker for this one too. Any questions about these?
Sorry, which ones?
The last two, just, because these are progressively getting worse, right? Like, just like in their marriage is getting progressively worse. So the last two are really needing a pacemaker if you can, for sure. Was there anything else in your notes about these that I didn't mention?
I mean, she did say that like second degree type 1 and first degree respond after pain,
Mm-hmm.
but then like second degree type 2 and third degree don't respond to after pain, so they would need a pacemaker.
Yeah, because it's getting worse, right? The stages are going from bad to worse. So. Yep. Let's think about time. Yep, it's about 3 o'clock. So you guys can just decompress for a bit, make a list of questions, and then Showalter will be back.
She's back at 4.
Yes.